Doptelet, avatrombopag, is indicated in adult patients with chronic immune thrombocytopenia who have had an insufficient response to a previous treatment. Important safety information is available at the end of the podcast. Dr. Jain has been compensated by Sobi to speak on this podcast. This podcast will reference data and evidence that are not included in the Doptelet indication for chronic ITP, and any topics discussed are meant for educational and informational purposes only. For any questions specific to this data, please contact Sobi Med Info at 1-866-773-5274. In clinical trials in patients with chronic ITP, 7% or 9 of 128 patients treated with Doptelet developed a thromboembolic event. Serious adverse reactions that occurred more frequently in patients with chronic ITP treated with Doptelet, 9% or 12 of 128 patients, compared to placebo, 5% or 1 of 22 patients, included headache, occurring in 1.6% of patients or 2 of 128 patients. Adverse reactions resulting in discontinuation of Doptelet that were reported in more than one patient included headache, occurring in 1.6% of patients or 2 of 128 patients. The most common adverse reactions in patients with chronic immune thrombocytopenia occurring in greater than or equal to 10% of patients were headache, fatigue, contusion, epistaxis, upper respiratory tract infection, arthralgia, gingival bleeding, petechiae, and nasopharyngitis.
Hello and thank you for joining us. I'm Shivi Jain, Associate Professor, Department of Internal Medicine, Division of Hematology, Oncology, and Cell Therapy at Rush Medical College in Chicago.
And I'm Scott Kolodny, the Senior Director for Medical Affairs Hematology at Sobi. And today we're here to discuss the findings from our recent post-hoc efficacy analyses of platelet count response to avatrombopag in patients with chronic ITP. I'd like to start by having Shivi define both the context as well as the aim of the current analyses. But before I do that, let me quickly kind of remind our audience about the original avatrombopag phase 3 clinical trial, which was entitled a phase 3 randomized study of avatrombopag, a novel thrombopoietin receptor agonist for the treatment of chronic immune thrombocytopenia, in which Dr. Jurasek was the primary author, and which was published in the British Journal of Hematology in September of 2018. This study was a 24-week or 6-month randomized placebo-controlled clinical trial comparing avatrombopag to placebo. There was a 2-to-1 randomization for avatrombopag versus placebo, and eventually 32 avatrombopag patients and 17 placebo patients were randomized in the core phase of the study. The core phase itself had 3 distinct phases. There was a 6-week dose titration phase, followed by a 12-week ITP concomitant medication reduction phase, and then an 8-week maintenance phase. There was also an extension phase in which previous placebo patients during the core phase of the study received open-label avatrombopag 20 milligrams, and 39 patients from the core phase entered the extension phase. The study itself found that avatrombopag was superior to placebo for the primary endpoint, the primary endpoint being median cumulative number of weeks of a platelet response, defined as a platelet count greater than or equal to 50,000, as well as the secondary endpoint of platelet response at day 8 versus placebo. One additional endpoint showed that the use of concomitant ITP medications was reduced with avatrombopag versus placebo.
This was not statistically significant.
So with this background, and before we go into the findings of your current analyses, Shivi, could you please explain both the context as well as the overall aim of the study?
Thank you, Scott. So after reviewing the very encouraging results from the initial phase 3 trial, this post-hoc analysis was done primarily to understand how the patient characteristics could influence the likelihood of loss of response in the patient population. Who will be the patients who will maintain response, and how long will they be able to maintain response? Loss of response was defined as platelet count less than 30,000 for either 4 consecutive weeks or for 2 consecutive office visits while taking avatrombopag.
Thank you, Shivi. Now let's move on to the actual analyses findings in the manuscript. and focus at first on the durability of the response with avatrombopag. Could you kindly comment on the durability of response to avatrombopag in adult patients with chronic ITP?
So according to the manuscript, the durability of response analysis showed that avatrombopag treated patients maintained their response for 84.5% of time on treatment during the core phase of the study and 83.3% during the core and extension phase. To note, 55.2% of patients in the core phase and 52.3% patients in the core and extension phase never experienced loss of response.
So, Shivi, let us turn our attention now to another aspect of the current analysis and look at the avatrombopag response in the core phase specifically of the phase 3 trial based on specific baseline subgroups. And let me define for the audience exactly what those baseline subgroups included. And these include age, sex, number of prior ITP therapies, prior TPO-RA exposure, ITP disease duration, and concomitant ITP medications at baseline, and finally, baseline platelet count. So if you will, kindly summarize for the audience what you found when stratifying the platelet count responses to avatrombopag by these specific baseline subgroups.
Thank you, Scott. As you note, among the patients that were treated with avatrombopag, older patients, which is defined as greater than or equal to 49 years of age, were more likely to achieve a response than younger patient, 100% versus 82.4%. But the median cumulative weeks of response was more favorable for the younger patients. Similarly, men seem to have a longer cumulative response duration from 15.9 weeks versus 9.6 weeks for females. Then if you look at, primarily when we treat ITP patients, this is a chronic illness, we want to see what kind of therapies the patients have received in the past. And, for patients who received less than 3 therapies in the past, these patients did have a better response as compared to patients who had received 3 or more therapies in the past. Similarly, there was a slight difference in terms of patients who had received previously another TPO receptor agonist, and also then the duration of treatment. Patients who had a longer duration of the disease actually were able to still show a response to avatrombopag. So the results were favorable, especially for patients who had received multiple prior therapies or had a longer disease duration.
Great. Now, what you just summarized for us was the core phase of the study. So let's look at the response based on baseline subgroups for both the core and the extension when we added the patients who were previously on placebo and then got open label avatrombopag in the extension study.
Right. So, again, having the data from the extension study just adds, to the fact that avatrombopag is for chronic ITP, because we want to look at the percent of patients who experienced no loss of response, which has been defined as platelet count less than 30,000 on 2 consecutive clinic visits or 4 weeks, right? And we also want to see the duration of the response. So we are trying to look at the durability of the response with avatrombopag. And you can see that younger patients did not, 62.5% of them did not experience loss of response, and the time of response was almost 91.2%. Again, 56.3% of the male population did not experience a loss of response. Individuals who had less than 3 prior ITP treatments, 72.2% did not experience loss of response. The study showed that this did not definitely predict the platelet count response to avatrombopag.
Great. So let's kind of summarize. We've hit the two basic parts of this, and that was to look at the durability of the response and looking at the response to avatrombopag by baseline subgroups. Are there any limitations to this analysis that you feel that we really should point out to the audience? This was not. I mean, for example, this was not an a priori design analysis from the study. So what does that mean? And, what should the audience know when they're looking at these results?
Great question, Scott. So I think the big limitation that I find for this analysis is the small sample size of the core study, as well as, the extension phase, which included patients who were on avatrombopag and also placebo who could kind of receive avatrombopag in the extension phase. So I think a larger sample size might help maybe bring out more differences and maybe show us more robust data to support the efficacy of avatrombopag. This is a post-hoc analysis, so we should interpret this data with caution.
So Shivi, as we wrap up, the podcast here, is there anything further that you would like to add for those who are considering avatrombopag for their patients, and perhaps those who have not yet tried but are considering avatrombopag for patients with chronic ITP?
Thank you, Scott. I will take this opportunity to bring up a very important point while managing patients with chronic ITP, which is shared decision making. When treating patients with this chronic disease, you have to take in a lot of patient factors that matter to the patients while considering treatment. We should also consider certain benefits like, lack of modification of the diet and, concerns about liver toxicity with this medication. So I would say we should consider all these factors when considering treatment, looking at the prior therapies, have they had exposure to previous TPORA, and then make a shared decision with the patient when deciding on treatment.
Great. So to wrap up, I'd like to first say thank you to you, Shivi, for participating in this podcast with me today and for kind of giving the background and explaining the findings for our audience for the analysis that you're the primary author and the leading expert on. I'd also like to thank the audience themselves for taking the time to listen today. And both Shivi and I hope you found that our discussion was both useful and informative. So is there anything final that you would like to say?
I would like to thank you for giving me this opportunity to discuss management and discuss this very interesting study on avatrombopag in our patients with ITP. And I hope we continue to contribute to advancement of care for our patients with ITP. Thank you.
Important safety information, warnings and precautions. Thrombotic and thromboembolic complications. Doptelet is a thrombopoietic TPO receptor agonist, and TPO receptor agonists have been associated with thrombotic complications in patients with chronic liver disease in 0.4% or 1 of 274 Doptelet-treated patients, and thromboembolic complications in patients with chronic immune thrombocytopenia in 7% or 9 of 128 Doptelet-treated patients. Portal vein thrombosis has been reported in patients with chronic liver disease, and thromboembolic events, arterial and venous, have been reported in patients with chronic immune thrombocytopenia treated with TPO receptor agonists. Consider the potential increased thrombotic risk when administering Doptelet to patients with known risk factors for thromboembolism, including genetic prothrombotic conditions and acquired risk factors. Doptelet should not be administered to patients with chronic liver disease or chronic immune thrombocytopenia in attempt to normalize platelet counts. Monitor platelet counts and for signs and symptoms of thromboembolic events, and institute treatment promptly. Serious adverse reactions. A serious adverse reaction that occurred more frequently in Doptelet-treated patients with chronic ITP in 9% or 12 of 128 Doptelet-treated patients, compared to placebo in 5% or 1 of 22 placebo-treated patients, was headache, occurring in 1.6% or 2 of 128 Doptelet-treated patients. The most common serious adverse reaction reported in Doptelet-treated patients with CLD compared to placebo was hyponatremia, 0.7% versus 0%. Adverse reactions. The most common adverse reactions occurring in greater than or equal to 3% of patients with chronic liver disease were pyrexia, abdominal pain, nausea, headache, fatigue, and peripheral edema. The most common adverse reactions occurring in greater than or equal to 10% of patients with chronic immune thrombocytopenia were headache, fatigue, contusion, epistaxis, upper respiratory tract infection, arthralgia, gingival bleeding, petechiae, and nasopharyngitis. Post-marketing experience. Following the approval of Doptelet, hypersensitivity reactions involving the immune system, including but not limited to pruritus, rash, choking sensation, swollen face, and swollen tongue have been reported. These are not all the possible risks associated with Doptelet. Please see full prescribing information for Doptelet at www.doptelethcp.com. To report suspected adverse reactions, contact SOBI North America at 1-866-773-5274 or FDA at 1-800-FDA-1088.